Thank you, Dr. Sikdar. We just had a very wonderful and illuminating session regarding CTOs. The next session of the day will deal with imaging in chip. Chairing this session will be Dr. Shubhanand Roy, Dr. Ashok Kaur, Dr. Amal Kumar Khan, and Dr. P.S. Banerjee. Our moderator will be Dr. Vishal Rastogi, and our expert panelists include Dr. Ishita Sarkar, Dr. Bipin Kumar, Dr. Rana Rathore Roy, Dr. Devapriya Mondal, and Dr. Sumit Shankar. May I please request the chairpersons and moderator to start the proceedings.
Fortunately, we have Dr. Robin with us on the expert panel.
Yes.
Thank you.
I logged in a wrong thing, so anyway, I'll go back.
Okay.
Thank you.
So I think we should start this session, and because the time is short and we are running on a tight schedule, it's a very exciting session of imaging in chip. And I would invite first Dr. P.K. Sahu to deliberate on OCT in chip, and then we'll go to IVUS in chip, and then we'll have Dr. Subhash Chandra's thoughts about the comparison. Over to you, Dr. Sahu.
Yes. Are the slides visible?
Yeah, they are.
Yes.
Go ahead, please.
Okay, so I'd like to just discuss about few cases about what is the role of OCT in chip cases. Now, whenever we think of a chip case, we think of a very complex anatomy, a surgical turndown, or major patient comorbidities, or biventricular dysfunction, or LV dysfunction, or the patient is hemodynamically unstable. Many times you get these non-emergent chip cases, which you usually do with multivessel disease, unprotected left main, and especially they have a poor ejection fraction, they are aged, they have peripheral vascular disease, and may have undergone prior surgery. Now, if you see the intravascular imaging in chip, what is the position? Complex PCI rests on three pillars. That is the anatomy that has to be done, on the comorbidities and the equipment. And here definitely intravascular imaging has a role in complex PCIs. Now, why do we need OCT in chip cases? Let us see, under expansion is a major problem in chip cases, and definitely we know that if we use OCT, possibly the mortality rates can be decreased because of stent thrombosis. Now, these three studies have clearly shown us that imaging is done in cases of whatever the type of cases, we have seen that the results and the long-term outcomes are better. Now, let me take up the first case. It is an octogenarian with a challenging subset, 85-year-old male. The age itself is against this thing him. Is a non-diabetic hypertension, luckily, but has severe scoliosis, cervical spondylosis, has got COPD. So these are certain factors where the surgeon is also reluctant to take. Has a chronic stable angina with recent ACS with a drop positive, a distal LMC is 60%, ostial to mid LAD 80 to 90%, borderline ostial LCX and 80% proximal LCX, the normal RCA, and all the arteries were severely calcific. So this is just the angio. What you can see is that the patient has got a very diffusely diseased LAD, and this is the disease that he has got, which is calcific in nature. And this is the circumflex, which also has got some lesions and also is calcific. Now, the right is luckily normal. So now these are the various lesions that were tackled up just to show the angiographic findings. There was a distal left main, there is an ostial circ, there's an ostial LAD, and also a mid LAD. So the plan was just first to, we can calcific, we discussed with the family, and we said that the age, COPD, severe scoliosis, and cervical spondylosis was against surgical this thing, so the surgery would be risk. And so PCI was considered as a very high risk in this case. Now, first of all, we had, it was a very tortuous aorta that we had. And for this tortuous aorta, we had to put a very long sheath so that we could have an access. Of course, so it was not possible to go through a radial because he was a very frail man, and we had to go through this tortuous aorta. Then the next thing was that so you can see the amount of calcium over here, both the circ and the LAD was rotablated, first with the 1.5, then with the 1.75, they were up upsized and they were rotablated. After the rotablation, first stent was put, that is a 3x38 everolimus saluting stent to the distal this thing, and then the third stent was put, and after that another stent from the left pin to the LAD, and a crush was done, and finally the wire was changed and a kissing balloon was done. So this was basically a left pin, distal left pin with a mid LAD and a circ lesion, and all three had to be tackled after this thing that is rotablation. And this was the end results where you can see the LAD is very nice and fully well expanded, and the circ is also good. And these are the final results. And this is the final angio to show you how this is. Now, what is the role of IVUS in this, OCT in this? In fact, the patient underwent OCT to show that the area was good and it was fully well opposed. And this is also the circumflex, which shows that the expansion has been very well and we have done a good job. And this was the OCT of the left, the LAD bid stent, which you can see the white line showing that definitely the position has been good and the stent has expanded very well. So now if you see the run from the L6 to LMCA, you can see that there's no strut across the crux, and naturally the lesion is very well dilated and the bifurcation has shown good results. So this is what was seen on OCT. Now we took a run also from proximal LAT to LMCA, and it was seen that the results were also good. So this was a very high risk octogenarian. We needed a rota stenting, and OCT definitely gave us the idea. First, what was the degree of calcium? What was the strategy to be done? And then what was to be done? So now this is a second case in which a LMCA trifurcation has been done. He's also an elderly man, chronic smoker, non-diabetic, hypertensive, again a COPD with an emphysematous lungs, has an old antival MI, and with recent ACS, the troponins was raised and has ejection fraction of 35%, and comes with ongoing angina with a distal LMCA, ostial LAD, ramus, circ, significantly occluded with RCA minor plaque. So in fact, we did an myocardial perfusion study. We saw that the LAD and the circumflex were still having viable myocardium. And this is just to show the angio to you. In fact, the PA catheter was put because there was LV dysfunction, and we could see that there was a trifurcation. In fact, the heart was a bit dilated, as you can see from the angio. And then revasc was proposed after the viability study. CABG was offered the first choice, but the risk was explained to them in view of the poor lung function on PFT, explained about the anesthesia risk, the cardiac anesthesia was there, and the need for prolonged ventilation post CABG. But somehow the relatives considered for PCI and consented with a refusal for surgery, and the risk with PCI explained. All the three were wired first, and then serially all three lesions were dilated, and all after wiring, pre-dilatation of the LAD, the ramus, and the circumflex were done. Then I treated the circ as the main vessel because that was the largest vessel, and I didn't want to pinch the ramus. In fact, I put the first LAD stent was put, then the stent to the ramus was put, then both a kissing balloon dilatation was done, and then finally a circ stent was put, and then the stent to LMCA was given. And this was also, this was the last stent that was given. And finally, a kissing to circ and ramus was done, followed by a kissing of, again, LAD, RI, and this thing, that is a ramus. All three, triple kissing was done, in fact, in this thing with 3 balloons. And finally, this was the result that we saw. And definitely the results were quite encouraging. Then after that, this is the pre and the post this thing angio findings. And we can see that all the 3 vessels have opened well. And just to know that everything was going on well, we did OCT of all the 3 vessels. This was the circ OCT. This was the LAD OCT, which showed that definitely the stent was well opposed. And this was the OCT of the, that is LMCA, which also showed that we had achieved the parameters that were necessary. So finally, LAD-L6 bifurcation was also seen, and it showed that definitely it was good. And OCT did help us know that the results that we had achieved were perfect. So what do we expect of an OCT in a CHIP case is that we all know that we need to search for any high calcium. We need to know the landing zones. We need to know the vessel diameters. And accordingly, we have to see at the end whether there is medial dissection, what is the position and the expansion. And this is as per the MLD max formula that we routinely follow. And the same thing follows for a chip, where we have to do quick runs and finally finish up the case. So my take home is that OCT is ideal for a strategy planning, stent optimization, detection of complications, leading to better short and long-term outcomes in chip cases. Thank you very much for the patient hearing, but we also know that every risk is worth taking as long as it's for a good cause and contributes to a good life. For you know, we can be the difference between the loss of life and the hope for future. Both my patients are elderly patients and they did well, and in spite of such a high risk procedure. Thank you very much for the patient hearing.
Wonderful cases, Dr. Sahu. Do we have chairpersons here?
Yes, I'm Dr. Kar. Can you hear me?
Yeah, sure, Dr. Kar. Please go ahead.
Now, thank you, Dr. Sahu, for your excellent presentation. And from your presentation, it is rather obvious that in all patients where we are going for chip angioplasty, we have to take help of this OCT. And so whether OCT is a better choice or IVAS is a better choice, till now we do not know. Now our next speaker, Dr. Devdatta Bhattacharya, he's going to speak on the role of IVAS in chip angioplasty. And after going through his presentation, then only we'll be able to know whether it is a IVAS or it is a OCT, or in selected cases IVAS or OCT. Yes, Dr. Devdatta Bhattacharya, next speaker. I think Dr. Bhattacharya do not need any introduction.
Yes. Can you hear me?
Yes. Yes, we can hear you.
Okay, I'm just trying to share my screen. Just give me a moment. Can you see my screen?
Yes.
It is visible. You are visible, your screen is visible.
Okay, thank you very much. Respected chairpersons, moderators, expert panelists, I am going to speak on imaging in chip cases with intravascular ultrasound. Now, taking into account, being mindful of the fact that this conference is being attended by a lot of juniors, I will try to take my presentation in such a way that those who are new to intravascular imaging can appreciate the logic and the rationale of why intravascular imaging is important in complex coronary intervention. If you look at the data of the NIC, the number of intravascular imaging cases has steadily increased over the past 10 years. But even at the latest data that we find, it is still under 10% of all interventions. So a lot of learning still has to take place, and younger generation of interventional cardiologists, I think, are even more enthusiastic about intravascular intervention. So this is my lecture is directed towards them. And in the end, I suppose we can have a discussion between IVAS and OCT in these really complex cases. So why intravascular imaging? Because this answers questions regarding coronary anatomy better than angiography. And in complex cases, you get into a lot of trouble by not being able to understand exactly what is the lesion solely by angiography. And that is because in intravascular, both by OCT and IVAS, you look at the cross section of the vessel along its entirety, along its length, and become more aware of its internal structure. So this is IVAS of a normal vessel, and you can see the intima, the media, and the adventitia. So since it has an inner eye 360-degree view, it is far superior to angiography in assessing lesion characteristics like what you want in angioplasty, like the proximal landing zone, the distal landing zone, the length of the lesion, and the composition of the lesion. So if you look at this, so this is a calcified coronary artery that has had a run of rotablation. And now we are going to look at our proximal and distal landing zones and the cracks by the rota. So this is our proximal landing zone, and it is a nice, as you can see, it is a nice zone where we can land our stent without much difficulty. This is again somewhere near to the proximal landing zone. Again, a nice nice expansion of the artery there by predilatation. Here you can see calcific lesions coming along, and you can see the rota cut. And then also what we have omitted here is the distal landing zone here, which appeared normal. So once we have an understanding of what to expect, then it is much easier to go in with a stent with much more confidence that your stent is going to expand. And it is not only doing intravascular imaging or OCT at the end of the procedure. It is very important to do a pre-IVUS or a pre-OCT before the procedure to see what we are exactly dealing with. So plaque composition and orientation is very important. Plaques can be soft, like this, as you can see in IVUS, where it is darker than the adventitia. It can be hard, where you can see it is more or less same as the adventitia. It can be very hard. You can see this napkin ring, and you can't see barely anything beyond it. It can be eccentric, which is very important because there are some lesions which are very tight, even tighter than this, and there is a very little part of the vessel that can expand, and very eccentric lesions, if you do not appreciate and try to overdilate them, you can sometimes end up with coronary rupture. And they can be concentric, like this lesion, not a lot of plaque burden here, but you can have very tight concentric lesions where the risk of rupture is less. And then if you are dealing with calcific lesions, one of the most the bugbears of angioplasty is calcium, and you really want to know what is the distribution of the calcium. So it could be one quadrant like here, it could be two quadrants like here, it could be three quadrants like in this picture, or it could be a napkin ring. And all this has an important bearing on how you are going to plan the case. If you see that your vessel has no, the balloon has no place to expand, like here or here, those are the cases where you need calcium modification. Whereas in these cases, there is calcium, but there is a lot of place for the vessel to expand, and you do not need it. Once you have assessed the vessel, the other thing that you really want to look at is what is the lumen at the tightest part of the stenosis, and what is the plaque burden, and what is the composition of the plaque. So here you can see that the lumen area is 3.34, the plaque burden is 76%, and it is a mixture of a fibrofatty plaque. So you would, and this is the circumflex, this is the circumflex.
Dr. Devdatta, you are muted.
Sir, please unmute yourself, Bhattacharya sir.
Dr. Bhattacharya, you are muted, huh?
Yeah, the host muted me. I hope I am not that boring.
Sorry, sir. From our end, we didn't do anything.
Please don't mute me. Okay, so this is what you want to look at. I hope that you were able to hear the previous slides. So anyway, I'm going forward. So this is the cross-sectional area of the lumen at the tightest part of the stenosis, and it is very important. This view is very important because it gives you an idea whether your balloon is going to expand or not. And remember, the plaque doesn't go away, and the plaque is not entirely compressible. So the vessel actually expands in a direction where there is not much plaque. Here it is a fibrofatty plaque, and this is the circumflex ostium. So this is a case of a left main where we are looking at the circumflex ostium. As you can see, it tells you immediately, so this is a bifurcation, it tells you immediately that you cannot get away without stenting the circumflex ostium. You have to stent the circumflex in this case. That is number one. And number two is how much expansion you can expect in this. You have a fair idea about the diameter of the vessel. You can go away, you can get away with a fairly aggressive pre-dilatation with a 3.5 millimeter balloon, and then you can take a cutting balloon if you want in this case, and then once you have optimized, you can go for a stenting. So all these things are available if you are doing intravascular ultrasound. So in the LMCA stenting, it tells us if the disease is significant in the LMCA. So if you have a patient who has a LMCA where you think it is 50% or 60% or a little less, and you're not sure, you do IVUS, and it immediately tells you by just measuring the cross-sectional area at the tightest part. If it is less than 6, the Europeans think it is significant. In Asians, the Korean data shows if it is less than 4 millimeters square, it is significant. You don't need to do any other thing, FFR or anything, just go ahead and stent it and deal with it. In bifurcation stenting, it tells us the plaque distribution in the main, the side branch, and at the carina. There is some background disturbance, so I would request other people to mute their microphones. Please mute your microphones. I am getting some noise in my computer.
Yeah, we are doing from our end, sir, and your time is up, sir. Possible, please.
Okay, I'll finish in 2 minutes. I'll finish in 2 minutes.
Sure, sir. Thank
So
you.
you remember you muted me for some time. So this is important in decision making if the side branch really requires stenting. In CTO, it helps us by distinguishing between the true and the false lumen. It can guide the puncture of the proximal fibrous cap, and it assists in a host of ways in retrograde CTO PCI, which I cannot address due to time constraints. Here you can see optimization of a stent. This is under expanded, and this is after full optimization. There is a mountain of evidence available that if done properly, IVUS leads to better outcome, and this is the ultimate trial already alluded to by my previous speaker. So what you want to see is that the plaque burden is less than 40%, 50% at the proximal landing zone. The expansion is satisfactory, more than 5 millimeters square, and there is no edge dissection. And if you do this, your final outcomes are much better than if it was a suboptimal PCI. And some formula worth remembering, this we all know, 5, 6, 7, 8. For non-LMCA, 5 millimeters square, no edge dissection, less than 50% plaque burden. So I would just take 2 minutes to finish this. So armed with this knowledge, how can the angioplaster solve problems in chip cases, improve his or her insight, and become a better operator? Here are a few examples. This is an IVUS guided LED CTO, and you can see that you can't see the proximal fibrous cap is ambiguous. You can put an IVUS catheter in the side branch, which in this case is the diagonal, and then do a pullback from that side branch. And then what you get to see, as you see in this IVUS, as it is pulled back, this is the LMCA that it is looking at. Beg your pardon. So this is what I want you to see. So you can see from this a pullback from the diagonal, and you can see the proximal fibrous cap here. You can aim your wire under direct IVUS guidance into that proximal fibrous cap, cross it, do pre-dilatation, do an IVUS again, assess the proximal, mid, and distal landing zone. I'll skip this and achieve a final result like this. And then you can do a final IVUS run, and you can achieve distal, mid, and stent diameters like this.
Dr. Bhattacharya, please wrap up the presentation.
I will just show one more case, and I will conclude. Just give me. I beg your pardon. I'm not going to show this case, just one more case and I will finish. So this is my final case. So this is IVUS guided RCA CTO, and this is very instructive. So bear with me. So this is the angiogram, and what we saw in this RCA CTO was that it was a very diffusely diseased vessel. We did the IVUS and we saw that the proximal RCA, although it looked very small on angiography, was actually 3.5 plus. We chose a distal landing zone. So these were our landing zones. We landed our stent like this, and this is how it looked at the end of the angioplasty. You can see that there is diffuse disease in the distal RCA, which we did not stent based on our IVUS findings. And I'll show you before concluding just one final slide. Really sorry that it is taking some time. So this is the final result post PTCA, and we do have a follow-up. Remember how the distal RCA looked here. And this is the follow-up after 1 year. You can see that all that distal RCA underfilling has gone and the vessel has regrown. And so this really helped us because we did not do stenting right up to the crux here, which was very helpful in this case. So I will not show you this case because I don't have time, and I do apologize for overshooting my time. What I would conclude is that the complex can be approached methodically by breaking it down to a number of simple steps. IVUS guidance, as I have tried to demonstrate above, helps in answering difficult questions not easily answerable by angiography alone. And these are cases that you can take knowledge from these type of cases, you can take forward into more complex cases, left mains, CTOs, calcified lesions, and you can get far better results than you get by angiographic guidance alone. So I conclude my talk here. Thank you for hearing. I apologize for overshooting my limits. And if there are any questions, I would be happy to answer. Thank you very much.
Thank you, Dr. Devvrat. Dr. Subhash Chandra, to please give your opinion about what is better.
Hello, can you hear me?
Yeah, please go ahead.
Yes.
Yes, we can hear you, Dr. Chandra.
No, just yes,
Doctor.
yes. Just before going to Dr. Chandra, because we heard the viewpoint from Dr. Bhattacharya regarding the role of IVUS in CHIP, and from Dr. Sahu the role of OCT in CHIP. But still, we do not know which procedure is better. From that, for that viewpoint, we have to go to Dr. Subhash Chandra. But before going to Dr. Subhash Chandra, I'll ask one question to Dr. Bhattacharya. Now, for CHIP, definitely, always you have to use IVUS or OCT for better result or for optimization of the result. But for routine angioplasty, whether we need IVUS or not, just to give your viewpoint.
Yeah, I think that is a very practical question. We do not use IVUS in most of our routine cases. What we do, however, is we use our insight from what we have learned from IVUS, and we use that knowledge while we are approaching our routine cases where IVUS is not being used. And what it has transpired into is that we know our stent sizing has become more optimal. There are certain parts of the coronary anatomy where we do not accept less than 3.5 millimeter diameter like the proximal RCA and the proximal LAD anymore, however small it looks on angiography.
But Dr. Devvrat, the stent size is better optimized if you do the pre and post IVUS in routine cases also.
Yes, I am trying to answer where you are. You asked me where, how do you, when you do not use IVUS, what do you do? So I'm trying to answer that question. If you have IVUS, obviously you do a pre-IVUS and a post-IVUS. And the fact of the matter is that we do not use IVUS in all our cases, in all our, and the NIC data tells us it is still less than 10% across all types of intervention. And it is only in some very high volume centers that IVUS is being used in some good measure, but a lot of labs, they don't have IVUS and they don't use IVUS at all. So they need to, if you do IVUS or if you attend courses or if you see these lectures, maybe you can have some idea about how to do it without IVUS and still come out with reasonably decent results. But if you have it, you should always use it in complex cases. That is my point.
Okay, thank you. Now, yes, now we have to get the opinion from Dr. Subhash Chandra. Which procedure is better, OCT or IVUS?
Right, sir. Thank you. After those two wonderful presentations defending the each technology, what are chip cases has already been alluded to by Dr. Sahu. And as this question by Dr. Kar was very relevant, that should you use these technologies in day-to-day practice? Yes, the answer was no, because of various reasons. Cost is one in Indian context, and secondly, followed by the volume which we deal with. But nevertheless, the complex and select cases where there's a long lesions or the bifurcations or CTOs, calcified lesions, should definitely be augmented by the technology which we're discussing here. So just to look at the evolution of these technologies, we realize that the IVUS came almost 30 years ago when POBA, BMS, DES was evolving side by side. And almost after 15 years of that, the OCT came in our practice. There has been a lot of data accumulating and largely in favor of IVUS because of its early onset. The prospect data was very, very enlightening on how the non-culprit plaques lead to coronary syndromes. And then, of course, a lot of data came on the OCT in the form of Illumin 2 and now Illumin 3. Illumin 4 is and various other trials. There have been trials to defend that why in complex PCI, the complications rates and the long-term follow-up can be improved by using one of these technologies. And there are a lot of future trials are there to answer this question, which I'm dealing with, that which one the technology is superior. Trials would be optimal infinite or Illumin 4 optimal PCI, and Optimus OCT versus IVUS. So this is how the IVUS has evolved since then, because of the fact that OCT was giving you a color television pictures and this black and white picture was no good. So the HD IVUS 60 megahertz has come in now to our practice, which gives pictures as good as what we see in the OCT. There has been hesitancy on part of operators because of the learning curve, and therefore it is very important to be conversed with how the images look like and how to interpret them. And I'm sure people attending this webinar on this particular theme jolly well know that how these various appearances like lipid or fibrotic plaque or calcified plaque looks on IVUS or on OCT. These are also some of the images where the soft plaque or calcified plaque or the thrombus would look on IVUS images. So it is very important to be confident about interpretation of these images before you embrace one of these technologies. And the last case, Dr. Bhattacharya showed the CTO technology is very well helped by the help of the IVUS, where you can clearly identify the true lumen from the false lumen, especially if you are conducting the dissections. And the true lumen will clearly have 3 layers of a normal artery as compared to the false lumen. So if you look at the guidelines, the IVUS has been selected cases to optimize the stent implantation. That is class 2A/B indication. It is also there to determine the severity and optimize the stent implantation in unprotected left main coronary arteries, again class 2A/B indication. And both IVUS and OCT are there to study the underlying mechanism of stent failure, class 2AC. And I would touch upon it, that OCT, how it scores over IVUS when it comes to identifying the characteristics of a plaque. And lastly, OCT in selected cases to optimize the stent implantation, again class 2B/C indication. There's ample data to suggest that if you use one of these technologies in routine angiographic angioplasty, your outcomes are definitely going to be superior. So as much as possible, if you're doing a complex PCI, you must use one of these technologies, as was evident from the ultimate trial. Calcium is another very big enemy for most of us as interventional cardiologists, and that is how we see it on coronary CTAs, angiographies, where you cannot assess the whole calcium, or it's so deep into the media. And black shadow comes behind the calcium, and the OCT, where whatever amount of penetration OCT has, it can clearly outline the thickness of the calcium. So this is how we compare the two technologies on the scale of pre-PCI estimation, post-PCI, and the follow-up. In the pre-PCI, the calcium is nicely estimated, especially in terms of the extent and the thickness, which guide your treatment strategies on OCT as compared to the IVS. And rest of the parameters, OCT scores over several other parameters as compared to IVS, especially for the characterization of the plaque. And then, of course, the stenting, both post-PCI and in the follow-up, where you can come across cases of restenosis, where OCT is very useful in terms of defining what is the actual cause of restenosis, whether it's because of neointimal growth or neoatherosclerosis or underexpansion of stent or progression of atherosclerosis at the border of the stent. That information is beautifully given by OCT as compared to the IVS. Level of evidence has been defined by the trials which have been conducted in past. For OCT Illumine 3 trial and opinion trials have suggested that this is a tool which is the future because of these very clear, looking at the very clear and nice pictures of the intima and the arterial wall. And therefore OCT scores here, if come to characterization, the internal of the artery. What are the eligible cases? Now, if you look at the ostial left main lesions, due to the impossibility of cleaning out the blood from the ostium at the aorto-ostial junction, perhaps OCT is not the best tool. And also because of the large size of left main, the penetration of OCT into the wall could be a problem. Therefore, IVS is your best option when you're dealing with the left main interventions. However, on the distal left main, where there's a trifurcation of Medina 111 lesions, OCT can still give you by 3D reconstruction a lot of information about dealing with the distal left main bifurcation angioplasties. Use of contrast, especially in renal compromised patients, is also one of the challenge if you want to choose OCT as your procedure of choice. And to overcome this, a single injection contrast, which can capture both the angiography and picture, could be a way forward, or choosing an alternate medium to clear out the blood from the field. A lot of advances have happened on this front, that IVS has gone to now 60 microhertz, where it could give you pictures as clear as the OCT. The IVS angiography co-registration has also come in practice now, just like the OCT co-registrations. Dual element IVS, where 35 and 70 megahertz transducers are compromised, were combined to look at the inner wall of the endothelium, as is the case with OCT, and the deeper walls of media by the other megahertz transducer. And that can give you the complete picture of the wall of the artery, especially in the in-stent restenosis. And lastly, the future lies in the hybrid IVS and the OCT single transducer, where this most advanced project by far can acquire IVS and OCT at the same time and can give you the exact picture of this thing. These are the advantages of OCT. Suffice to say that it is 10 times more resolved and resolution is much better. However, it is compromised by its penetration, which is much better by the IVS. In acute coronary syndromes, OCT can give you exact definition whether the acute coronary syndrome happened because of the plaque rupture or erosion, or there's a calcified nodule, and what should be the strategy to treat these patients, whether just leave them alone in medical management or do something. And if it is a calcified nodule, which atherectomy device should be chosen to reconstruct the bed. And finally, the relevant guide to the treatment and determine what is the best strategy to treat these patients. We know that the calcium is better and the best picked up by IVS, even as compared to the OCT in this trial, as you see here. And the calcium is the biggest bane because it leads to high MACE and other complications in the interventions. In OCT itself, there have been a algorithm where a 4-point algorithm can give you a lot of guidance that how to treat with the calcified lesions in day-to-day practice. And this is just a chart that if you can't pass your OCT catheter, you in a very tight calcified lesion, you might have to take help of rotably, then decide IVL could be of help, or any other device or a small balloon in calcified lesions. This has already been dealt with, that depending on the pre-PCI capture, you can decide that what kind of device is required to prepare your bed and how the stents can be best apposed or deployed in these trees. If it is a concentric calcium, rotational atherectomy is a choice. If it is an eccentric calcium, orbital atherectomy could be of help. And you have to see post IVL that whether fractures have been caused into the calcium, so as to ensure that the best stent implantations happen after this. This is a case where you can clearly see there's a narrowing, and here it's because of the ACS is because of the plaque erosion rupture here as shown in the IVS, but a lot of clot is being seen in OCT, which was missing in the IVS picture. And after the stent deployment, there is a plaque prolapse, which is nicely shown by the OCT. So I must say that both the technologies are complementary to each other. The resolution, the surface detailing is favoring OCT, whereas penetration, media to media sizing, the bulk of clinical data favors IVS as of now, but OCT is the way to go. One has to be careful about sizing, and one must choose the most accurate size as given by the OCT. And this has already been shown by my previous speaker, Dr. Sahu, that how MLD Max protocols are embraced these days in the common day angioplasty, especially dealing with the complex cases. And with that, I will end it here. This is the Octopus trial, which we are keenly looking forward to, that how OCT and IVS have been combined and what is the best way. The future could lie in a hybrid catheter, which combines both IVS and OCT, the IVS giving to the deeper detailing of the artery, and OCT giving you the best pictures in the surface of the artery. And with that, I'll conclude it here and leave it to the experts to decide that between the two technologies, which is the best. And I feel that they both complement each other. Thank you so much.
Thank you, Dr. Chandra. Now, Dr. Chandra, I'll ask you one question.
Next
Yes.
speaker, Ahmed.
Yes, I'll ask one question to Dr. Chandra.
Please.
Yes. Now, in your lab, you have got both the devices, or you have got one of the devices?
We have both the devices. Sir.
And because you said that both are complementary, because some plus points and minus points are there in both the devices.
So if I may tell you that if I'm conducting a research on a particular stent and I want to give some data, my choice tool is the OCT, because I want to look at how best the struts are embedded, and in the follow-up also that how the new intima has been covered by the stent struts have been covered with the new intima. When it comes to doing bigger arteries, and I use it more and more in my practice. So between the two, I would say that I have an inclination for a compromised patient. I would rather not use OCT because of causing renal impairment by pushing a lot of current.
So that means we are going to have a hybrid.
18 minutes video na. ఇప్పుడు కాదు కదా 6 కదా అది ఉంది ఏమే it's ready.
Okay, any more questions?
There is absolute chaos in the background. I mean, a lot of people are talking and
వచ్చినట్టుంది బా చోప్రా కదా కరెక్ట్ లేదు.
Please can the organizers mute the other microphones so that if there are any questions, we can answer them. Yeah, I think Dr. Subhash Chandra summed it up very nicely, and he didn't go for either. I noticed that in the end he left it to the audience to decide. And the reason for that is both the techniques are complementary, and anyone who has done intravascular imaging and has some experience in doing both the modalities would appreciate that there are some times when you want IVUS and there are some times when you want OCT. And in calcified lesions, as he showed the images, the thickness of the calcium is much better appreciated by OCT, which IVUS doesn't do. However, the HD IVUS has changed our view of these lesions somewhat, and we are seeing more of these details at the near field that we didn't used to see earlier. And Dr. Shahu showed us an excellent series of cases, and he compared with OCT. And maybe Dr. Shahu, you can tell us about your experience.
Unmute yourself, please, sir. Dr. Sahu? Dr. Sahu, unmute yourself.
I have both IVUS and OCT with me. In fact, we have the HD IVUS also. So that is why sometimes what I do when I don't understand the images, I do both the modalities, if it permits. And then I compare the images because it is daily a learning this thing. It is a learning way for us. But the HD IVUS has a lot of advantages over the traditional IVUS. The images that we see are almost comparable to OCT. That's the whole thing. Of course, when we do cases with octogenarians, when we do high-risk cases where you don't want to push contrast, as Dr. Subhash Chandra said, IVUS scores over it. If it's an ostial left man, no business of an OCT there. It has to be an IVUS. So there's some certain subset where IVUS is mandatory. And the best part is you can do as many times as possible as you want without pushing any contrast.
CTOs as well. You would agree?
Yes.
Yeah.
So, Dr. Vishal, as a moderator, would you want to wind it up?
Yeah, I think this was excellent deliberation from all the speakers. And we saw that both the modalities are complementary and a lot of advances are happening in all the fields. And as we are going towards more and more complex cases, our understanding about these devices and our dependence on these devices is increasing. And we need to have a command of both. So I think we have overshot the time, and I thank the organizers and all the speakers for their excellent presentations. Thank you so much.
Thank you, sir. Thank you, Vishal.
Thank you.
Navneet, we should go to the next talk because we are already late.
Yes, sir.
So
Thank
we
you, sir.
follow up
Thank-
with the next session.
So thank you, respected chairpersons and speakers, for this enriching and illuminating session regarding the use of IVUS and OCT imaging in CHIP.